Good evening. Hi, everyone. Let me know if you can hear me.
Wow,
Yes, we can,
experience.
Doc.
I just love
Right. Thank you. Thank you. So welcome to today's webinar. It's now 7 o'clock. And thank you so much for joining. And even as the rest continue to log in, I welcome us to introduce ourselves on the chat section. Just put in your name and where you're joining us from. And I see my friend from Egypt. Karibu sana, Ala, and the rest of us. We welcome you to today's webinar on pediatric comfort at the end of life for children and families. We are looking at caring for children and their families when they get to the point of end of life. What are their wishes? What is important really? So sometimes patients will get to end of life, but then we remember that palliative care implementation or provision does start from the beginning of a life-threatening illness, whatever illness it will be for adults and for children. So we are privileged this evening to discuss this. I'll be your moderator. My name is Dr. Esther Mwinga. I work at the Ministry of Health in Kenya, the Division of Healthy Aging, Palliative Care and Older Persons. We call it HAPCOP in short. That's the division at the ministry that leads matters to do with palliative care policy and implementation. And today we are happy to have Callie Daniels, doctor, who is a research manager at the International Children's Palliative Care Network, or ICPCN in short. ICPCN is the network that internationally coordinates palliative care for children and has done a lot of work in terms of scaling up service, training, education, issues to do with policy. Dr. Callie is a research manager at ICPCN, and she holds a PhD in global health and anthropology from the University College London and has worked in different continents, including Africa. Specifically, she's also worked in Kenya, utilizing qualitative, care-driven, and community-engaged methodologies in children's palliative care and end-of-life care. She's a great researcher and is very passionate about the work she does. And thanks to Kehpca, Kenya Hospices and Palliative Care Association, which is the umbrella body for palliative care in Kenya, we are able to have Callie in this webinar. So I'll hand it over to her, and thank you all for introducing yourselves. I see people from Trans Nzoia, Eldoret, Nairobi, Busia, Maua, Mexico. Yeah, thank you, Alexandria. Thank you. Thank you all for joining. Keep introducing yourselves on the chat. And if you have any questions for our speaker tonight, just note them down on the chat box. We will be able to respond to them at the end of her session. So Callie, feel free to share your slides. I see someone else from Kolkata. Karibu. Karibu means welcome. So welcome. Gilgil. Yeah. Malawi. Great. Yeah, so as people keep joining, we'll know who is in the room. So over to you, Callie. Your screen is visible. You can go ahead.
Wonderful. Thank you so much, Esther, and to all of Kehpca for having me today. It's great to be here. And as Dr. Esther said, I lived and worked in Kenya for many years, since 2009. And this research was based in Kenya as well. And so I'm very glad to to get to present to the palliative care community in Kenya, and hopefully have a conversation about what it might mean for you all who are providing care directly in your context. And while this research is grounded in Kenya, I believe that it has implications and things we can all learn from many contexts. And so for those who are joining from outside of Kenya, I'm also very glad to see you all here, and look forward to the conversation we can have. So I will share a bit about my research, and then I hope we have time for a rich discussion following. So as Dr. Esther said, my name is Callie Daniels Howell, and I am the research manager for the International Children's Palliative Care Network. So also very happy to discuss ICPCN. But today I'll present some of my research that was part of my PhD work at University College London, that was based in Kenya. And I will say that I am a medical anthropologist, so I'm a social scientist, and so I look at things from a slightly different perspective, and so I'll share some of that with you, and then some ideas about what that might mean for those of you who are directly providing care to children and their families. And I'll discuss more about the methods, but we'll note that much of the methods came out of while I was working as a social worker on the ward, and so my experience with clinical care for children and their families is from the role of a social worker. So this research was on wanting to understand from a social scientist perspective, or from the perspective of kind of a holistic picture about what families experience and is meaningful to them around the time of a child's death and end of life from childhood cancer in Kenya. And then using kind of my perspective as an anthropologist to think about what that might mean for how we could best provide care for children and their families throughout the illness experience, and then also particularly at the end of life for those children who do move toward death and die from cancer. And so I'll present a bit of that today. So as you all know, we know that there is great need for palliative care for children globally, and in Kenya in particular, that need is high, and for children with cancer. And we know that palliative care still is limited for many children in Kenya, and particularly end-of-life care is still limited for many children. So I previously did research at Sunflower Children's Hospice in Bloemfontein, South Africa. And from that study, I was looking at a term that you may have heard, the concept of a good death, which we hear a lot in palliative care discussions about the concept of a good death. And so I was looking at the extent to which that concept really was applicable and relevant in South Africa for families who often were very economically constrained, whose children were facing multiple illnesses and vulnerabilities. And I found that really what we needed was to develop very close understandings of a child's death and dying from the perspective of their families, what this meant to them, what that process looked like, what they desired in that time, what was important to them, and use that to develop care around the end of life. As you all know, the end of life is a very intimate, sensitive, spiritual, emotional space of life. And so I found that we really needed to develop close understandings from families' perspectives, and have that drive then how we best provide care, so that we are caring for families as holistically as we possibly can in that time. rather than sometimes taking external kind of concepts like the good death and trying to kind of apply them to Kenya. We needed to drive it from families directly. And so that's where this study came from. We know, though, that in Kenya, a child's death is often not openly discussed in advance. And there are, for many children, there are many influences, many issues that are influencing their illness and their death. Economic constraints, health system limitations, distance between home and hospital, many things that influence this time of a child's end of life beyond just the sort of physiological process and symptoms at that time. And so what end of life care should look like is complicated. And unfortunately, our research around that space is still very limited. And so I thought about the space between illness and death of a child from cancer. And so in Kenya and in Kiswahili, the study is called Nafasi Kati, the space between illness and death. And we wanted to understand what that is like from the perspective of families. And then start to think about, based off of everything families told us, what could care look like? What would it look like really to go from kind of a family's perspective up to develop care for children who do unfortunately die. So as an anthropologist, this was a qualitative study. It was very iterative. It took an approach that was guided by an ethics of care. And by that, I mean that my research team and I were guided at every decision point about how we should study, what methods we should use, if we should ask this question or not. We were always asking, what does it look like to care in this moment? And then tried to follow that approach. And so that meant that our study changed shape many, many times throughout the course of data collection. And as much as possible, we made space and encouraged families to answer that question with us and for themselves about what would be most caring to them as they participated in the study. And so this took place between 2022 and 2023 for about 16 months. So I first, as I said, was on the pediatric oncology ward at Moi Teaching and Referral Hospital, working as a volunteer, a kind of assistant social worker. And so was on the ward full time, providing bedside care as a social worker to families. As I did so, I was conducting ethnographic observation, and so really just taking in as much as I possibly could about what the experience in hospital was like, and was present as many children died and their families kind of experienced the immediate space after their child's death. Then we took 10 months of ongoing narrative interviews with the families of 9 children who I had met and who died in about March and April of 2022 while I was on the ward. So these were children who I knew while they were living, while they were receiving treatment for cancer, and then through the end of life. And we began working with their families about 6 or 8 weeks after their child died, and then through the first year of bereavement. And in that time, we kind of continued telling stories with their families, through repeated home visits over that year. And as much as possible, we asked families to direct kind of what they would tell in their story, who would participate in the storytelling, what they would share, how much they would share. And so wanted families to really guide that process rather than kind of telling us a very specific story that we were verifying or fact checking, allowing families to share as much as they wanted. And so for some families, it was just a single parent who shared throughout the year and in shorter segments. For other families, they had large extended families that they wanted to be part of it. And so we had 8 or 9 home visits and many, many kind of minutes and hours of recordings of them telling their stories. Throughout that time, we also gathered all of the 9 families in one central location for a day-long meeting where we provided peer-led grief education and support through the partnership with the Tears Foundation based in Nairobi. And I'm happy to discuss a bit more about that in the discussion if you'd like about that. But that was an example of where families asked us for more grief support as they were telling their stories. And so we partnered with Tears and found a way to kind of incorporate that. And so an example of where we shifted and changed directions based off of what we heard from families. So as this was a narrative study, today I will share some of Brian's story and what it might reveal to us about what that space of the end of life is like, and a picture of what holistic care might look like for families. But as I've noted, I do hope that we can discuss that together rather than hearing from me very specific recommendations of what you should do, but what we can learn from these families' voices together, and what that might mean for your particular context. So as I share Brian's story, I do want to note that all of the pseudonyms used for the children were given by their families, and any other identifying details I have altered. So I met Brian when he and his mother arrived to Subira, the pediatric oncology ward. And when I met them on their first days in hospital, what I remember most was Mama Brian told me she still did not know what Brian had been diagnosed with, despite Brian already receiving chemotherapy. As we followed Mama Brian in the year after Brian's death, though, the nature of that point when I met her gained a lot more depth and complexity. And so I'll share some of what I learned from Mama Brian in that year. Brian was 9 years old when he became ill. Brian lived with his mother and 2 older siblings in a slum within a mid-sized city that we'll call Noura. His father left the family sometime after Brian became ill. His single mother, Mama Brian, was a hawker at the bus stage and made about 500 shillings, equivalent to about $3 a day. When Brian started having eye problems that would not go away, Mama Brian first took Brian to various dispensaries and public district hospitals where they were told there was nothing wrong and sent back home. But Brian's illness continued. And so Mama Brian decided to try something different. So she took Brian back to her family's rural home about 6 hours away by Matatu. And there she took Brian for prayers and to other traditional healers. But these did not bring any changes either. Brian then became paralyzed from the waist down. And Mama Brian decided to take Brian to the public referral hospital in the city nearest her family's rural home. The hospital referred Brian to Moy Referral Hospital, telling Mama Brian that she needed to give 20,000 shillings, or about $175 for the hospital to transport her to Moy. But Mama Brian did not have that much money, so she returned home. She continued taking Brian for prayers and to traditional healers. She said about many people telling her where to go and what to do, and that she should go to traditional healers. And she described, you cannot ignore those words. Or you would just say, let me go and confirm what they told me. Let me go. So-and-so went and got well, and he was just the way this one is. Will you fail to go? It's a must to go, because if you fail to go, just the way he left like that, they would say, I told you to go there and the child would have been all right. I went everywhere. But then Brian's eyes and legs turned white. And so Mama Brian took him to another public referral hospital in Noura. That hospital asked Mama Brian for more money to run tests, and then again referred Brian to Moy Hospital. That hospital in Noura told Mama Brian she had to pay 25,000 shillings, approximately $200 to be allowed to leave under the detainment policy that was, as we know, is common in many public hospitals for those who cannot pay their bill, that they must pay their bill before they can leave hospital. But Mama Brian did not have that much money. Mama Brian and Brian were then held in that hospital in Nora for 2 months while trying to find money to pay Brian's hospital bill. But after 2 months of staying in the hospital in Nora without treatment, Mama Brian believes that the hospital saw that Brian's condition got worse, and so then they told Mama Brian to pay everything she had and they would let Brian go. So she gave them 10,000 shillings, all she had collected and saved, and they transported Brian directly to Moy Referral Hospital. When Brian and Brian arrived to Moy Hospital, which is when I first met them, Mama Brian described to us in her story that Brian was treated very quickly without them ever giving him more tests to find out his diagnosis. She said, "When I got to Moy, they dealt with me so fast. I don't know if they had the results there because they never tested him. I think they knew it at the hospital in Nora because they began giving him medicine. I don't know, I gave them papers that I came with from Nora and they started treating him quickly." Mama Brian realized that the hospital that detained them must have known Brian's diagnosis the whole time that they were held there. Much later, after Brian died, Mama Brian looked through the hospital papers and realized that the first hospital that had referred Brian to Moy had also diagnosed him with cancer, but had not told her. Mama Brian had been holding Brian's diagnosis in her hands for months before he was finally treated, at which point it was too late. She said, "If I had known those papers, I would have taken them and gone to Eldoret direct. Would I have received help? Now that, sometimes I do the math, sometimes when staying, I just leave it to God." She then said, as describing this going back and forth, "I saw it as stupidity that I was doing, but it's not stupidity. Losing my way is what I was doing." After 2 months at Moy Hospital while Brian underwent treatment, Mama Brian was called to counseling. And she described, "So when I was called there, I just knew that this child has left me. God give me strength. So I knew it that when you are called there to counseling, it's only 2 options. He gets well or he leaves." Mama Brian begins to pick up on cues as she watches several other children on the ward around her begin to physically deteriorate and then die. And she says, "I then knew it from there that when someone is going to die, their legs and hands turn cold. But I could not tell her, another mother of a child in her room, that the child was going to die. I told her, 'The child will be okay, Mama Princess. This one is okay and will get well.' And after a short time, she left." But then Mama Brian began to see those same signs in Brian only a couple of days after Princess died. She also noted the different way that the clinicians were speaking to her, and this confirmed her suspicions that Brian was going to die. She said, "I just said death is here. Like mine, really that one he had gone. There is just a line, a day will just come, and God's plans you cannot unplan. But it was hard. So toward the end I said this has happened and it has happened. Even if I pray, because there in the beginning I used to pray completely. I used to pray for my child to get well. Now that it has come to an end, I just leave it to God. Let his will be done, because there was no otherwise." She continued to say, "It's better not to know so as to just get shocked, because it disturbed me the whole day. I am telling you, it's better to be surprised than to see how he is going, how it ends. I don't see that picture going out from my eyes my whole life." Mama Brian described that she could tell that Brian was dying, but no one was saying anything to her, and so she sat there and just waited for it to happen, feeling like there was nothing she could do but wait. After Brian did die that afternoon, Brian's body was again held in hospital in the mortuary until Mama Brian could pay the balance on his hospital bill from before her NHIF at the time finally activated with the support of the pediatric oncology social worker who helped her move through the waiver committee process. But that process took several months. And she described, I think when someone loses a child, they should be brought close. Or I was left hanging that way. I had no one to help me. I had lost my child, but I was walking on the road looking for money. This led Mama Brian to consider burying Brian at a public cemetery, something that was very distressing to her, as you know, in the Kenyan context. It was it's custom for Brian to have been buried on his paternal ancestral land, but her husband had left, and so she had no access to that burial space, and her own family was also refusing for him to be buried on her ancestral land. And so she described, I almost called to ask if there are public graves there in Eldoret and tell them, I don't have a way forward or back. Take that child and bury him there, and I will be done with him. And I will keep in mind that I had a child who was buried there because I had nowhere to take him. But finally, a month after Brian died, the hospital committee did waive the remainder of Mama Brian's hospital bill, and she was able to bring Brian from the mortuary. She had finally gotten her own family to agree to bury Brian on their land. And that day I was with her in the mortuary when she was able to see Brian's body again, and she wailed, saying, "Today my child is really dead." Later, Mama Brian described to us, finding money was hard. The way the committee helped me, let them go on that way. Let them go on helping people, because if they had left me alone, the child would not have left there. He would not have come out. He would have remained there because I had no money. Brian had been there for almost 3 months, and the bill for treatment was high. It was about helping each other, and that committee helped me a lot. I don't know where I would have leaned on. And then later, as we were conducting the study, and Mama Brian looked back at those discharge papers as I described, and learned that Brian had been diagnosed and that it was written AML, the disease that she now understood he had. She described, when the child was already dead, now when I was looking at those papers, I saw that they had written that disease. He has the disease. Now I did not see it when I was there. Now when the child died is when I started looking at those papers that had been written. Turns out they knew it. That's why they told me to go to Moy. Now I did not see those papers, and they did not tell me that the child had a certain disease that I should take him quickly. They did not tell me. Turns out they knew. And so, as I described, it was only after Brian died that Mama Brian realized that both hospitals that had referred her to Moy had known that Brian had had cancer and did not tell her, including the second hospital that had detained Brian for 2 months without treatment. Mama Brian had been holding Brian's diagnosis in her hands that whole time. And this led her to question, when I look back, question what she could have done and what might have happened if she had known what the papers were that she was holding and why he was being referred. But she said, at the end of our year together, when I look back and think of how Brian died until now, I just feel I am okay because of you. I don't have any stress about Brian's death because you have been visiting me this way. All I can say is you made me feel okay. I am very okay, and I am not exaggerating or lying to you. I am okay because of you and when you started visiting me. Even people saw that I have my sisters from the hospital. Let us visit each other. Let us visit those who are that way, those who encountered problems, and give them strength. If I can tell them my story, they might say theirs is better. They are okay. And we actually just visited Mama Brian a couple of months ago, and this continues. Mama Brian continues to find meaning in us visiting, and particularly in having space to continue being Brian's mother. Though she initially expressed at the end of our year together that she wanted to put Brian behind her, and that she was ready to move on. When we gave her her story a couple of months ago, she described being glad to find that her words were commemorated just as she had told them, and for Brian to be remembered and for it to be noted down that what had happened to Brian and to her. And she was, I think, particularly glad to have a space where we could call her Mama Brian, and for Mama Brian to still exist in the world, while others around her had stopped using his name or had stopped referring to her in that way. And so that continues to live on today as I share her story. But this is also not just about one family. We see similar themes echoed in the voices of other families, each with their own complexity. So I'll share some words from some of the other families as well. Baba Goatman said, "Inasmuch as I was with him until the last minute, it was very, very painful. We were a gradual death. It was when you see, this boy is dying, this boy is going. It's coming slowly. In one way, it is good, but the other way, it's very painful also. A situation where you as a parent, where there's no way you can help your child. How would you feel?" Baba Kimo said, "The doctors should also know that we lost Kimo. But why did we lose Kimo? How else should they have helped Kimo? That is what I hope they can tell us. What happened?" Mama Faith said, "I realize that it's likely they are just waiting for the day." She's describing this as she realized that the doctors were not speaking to her right before Faith died. And she said, "From then on, I had no peace. Even the child no longer had peace. Every day she would ask me we go home and not let nightfall find us there. Turns out she also felt it." Mama Divine said, "My instincts or my wish was not to leave my child. I just wanted to stand by her side and help her within my ability. I did not want anyone to remove me from that room and take me to another room. I just wanted to go there, hear her while she was speaking. I said it's better for me to stay there and help her. I did not want any disturbance that would move me from the patient's side to go anywhere else." And another said, Mama Anastasia, "That last week, I just think it's prayers because she told me, 'Mommy, pray.' But it reached a point I was unable to pray. She told me, 'Mommy, pray.' And I told her, pray. She instructed Anastasia to pray because she knew how to pray. And Anastasia told her, 'No, Mommy, pray.' And Mama Anastasia wondered, but what do I really pray? There was a time I even thought God had left me. When others said, 'God is wonderful,' I said, 'How wonderful?' It was like, what were my prayers for?" So these stories and their voices are hard and difficult to hold. They hold immense suffering and complexity. And we see that from some of those snippets that Mama Brian and Brian's story are echoed across the narratives of all 9 families and their children that we worked with. But we also see that they were complex and diverse, even within one hospital. They all had different features of their progress through illness and through the end of life. They also had different challenges and different aspects that were most important to them, that they desired most, that they needed most support with. And so I'll highlight a bit some of the patterns that we heard from all families now, but know that this is complex and that likely in the context where you are working, it is also complex across families and across the particularities of their experiences. And I will also note that some of these findings around the health system and aspects of their experience really aren't about any one person or decision, but reflect how the system, including policies, infrastructure, shapes what's possible in daily practice. And so I encourage us then to think about what that could mean for those systems in the context where we all work. So across these stories, I think we found as a child approaches the end of life that, as you may have seen in Mama Brian's story, families and particularly parents and the primary parent who is on the ward, if they're in a context where only one parent can be there, are in a constant process of trying to make sense of their child's condition and what it means. And we found that this was related to parents' desire to continue trying and exerting effort around their child. And this kind of trying was a means of continuing to keep their child alive and care for them and continuing to fulfill their role as a parent. And so we found parents were always looking for ways to make sense of their child and to continue to act and actively care for their children throughout the end. And this often looked like trying to piece together various cues. Parents were not always given very substantial information about what was happening to their child or their child's prognosis, but they were picking up on many things. We saw this in Mama Brian's story. No one directly told her that your extremities going cold is a sign of the body deteriorating or moving toward active death. But she picked up that when a child's hands and feet get cold, that means that they're approaching death. And she saw that pattern replicated so many times on the ward that she then started to be able to predict when a child might be approaching death, including them when Brian was approaching the end of life. So we see that parents often held substantial knowledge about their children, but they didn't always know how or when to communicate that to clinicians, or were always clear about what information doctors wanted from them, such that they weren't necessarily always clear when to ask for help from a clinician. But also because they were not receiving kind of explanations of some of these things from clinicians, they often were very isolated and alone when they were making sense of this. As we saw in Mama Brian, she realized that Brian was dying, but there was no one supporting her in that. That was all internal and her own experience to make sense of. And we can see from some parents, that there's also a sense that their children know what is happening. This was emphasized by several parents, that they had a sense that their child was aware that they were going to die. And that was very distressing for the parent, not necessarily because I think they found it very devastating that their child was aware they were going to die, but also because they didn't have a means to help them with that experience. They felt as if they and their child were just waiting, or that they didn't know how to make sense of what their child was articulating to them. We saw that families really rely on peer relationships to navigate the stress of the hospital experience and of their child's illness, and to make sense of their children. And that can be a very positive resource, but it can also lead to confusion and stress as they are constantly comparing to one another. So at times we would hear parents, and I would see them frequently on the ward, note that particularly something like counseling, if they went to counseling, as Mama Brian described, if a parent was called to counseling, and many children would die soon after that counseling meeting. And so if they were ever called out by the doctor, they would become very stressed, assuming that meant that their child was also going to die soon. They might notice that one child received a certain chemotherapy and then seemed to die, and so they would get very afraid that that meant that if their child ever received an IV bag like that, their child was going to die. And so at times that helped them make sense of what was happening, because as I said, families deeply wanted to understand their child's prognosis. But at times it could also be very distressing, as sometimes they made connections that weren't necessarily certain for their own child, and it increased the sort of level of stress across the board. We also found that parents in the hospital and at home were frequently very stressed by the hospital system and the responsibilities put on them within this, particularly as their child moved toward the end of life. For instance, one father said to us, "You despair in that place because there is no blood." And many families highlighted particularly the blood bank and the challenges of receiving or donating blood to be able to give blood products to their child, and particularly at the end of life when their child was had an acute need for blood. The level of pressure that was on them to get their child something that might keep them alive. And that father was traveling to Eldoret to donate blood for his daughter, and she died while he was in the Matatu en route. And so he continues to question what might have happened if he had gotten there sooner, and if it is his responsibility, or he was at fault for her death. We also see across the experiences that family, community and family and spirituality are very complicated. Sometimes we think of communities or one's faith as only positive resources or sources of support for families. But many families describe to us many challenges and isolation from community throughout the experience, and particularly as their child was approaching the end of life. Many also had substantial crises of faith and doubt in God, which distressed them further, as everyone around them, the clinical team and their community and family, was telling them to pray and believe, and they were having these questions about how to do so, and how to make sense of what they saw was happening to their child. So this meant that many parents described feeling very alone, while also relying on their faith and a sense of divine will as a way to kind of keep space open to care for their child. Even as they saw their child was deteriorating, a sense of, while they questioned their faith and spirituality, they also relied upon it to kind of make some uncertainty in what was happening, that and a meaning in what was happening that allowed them some space to continue caring for their child. We saw this very frequently in how families related to information and communication. Families hold very complex relationship to understanding their child's prognosis, and their impending death and deterioration. As I said, many families were in a constant process of collecting and interpreting signs to make sense of their child's status. And many parents did describe wanting more information and trying to find ways to get this from doctors. Also, family then would notice and interpret what it meant when doctors avoided or began telling them conflicting information about their child when they deteriorated. That was a significant cue for families that their child was going to die. That being said, many families also did not want to be told certainly. Many families wanted to not have it directly articulated to them that their child was going to die, even if they knew it in kind of the back of their mind or in their heart. And we see that to not be told is not the same as to not know. As Mama Bryan's showed, families understand a great deal about their child, even if they are not told this directly. And so many families experience the moments before their child's death, knowing that it is coming, but without any information, guidance, or support from clinicians, and leaving them isolated, confused, and distressed by their child's physical symptoms, and often feeling helpless or resigned. As Baba Goatman said, you're just there with nothing to do as a parent. But we saw in Mama Brian's reflections that she wished she had not known that morning that Brian was going to die. She felt she was just sitting there, seeing that Brian would die with nothing to do but wait. And other parents echoed this. They could see that being prepared could be helpful, but also noted that just waiting for their child's death left them feeling like there was nothing more they could do for their child, and described this as the worst possible feeling as a parent. Some families noted and appreciated when they had direct conversations with clinical staff, but they might want slightly different frame of communication. Most reflected that they appreciated getting some information, but didn't necessarily want a specific prognosis from that information. But they wanted support in this kind of process of making sense of their child's illness on their own. And so they wanted pieces of information that would help them along the way without necessarily kind of a definitive announcement that their child was going to die. Others, though, noted that many of those conversations happened only right before the death and outside of their room, so that they were pulled away from their child right when they felt that they were most needed and most wanted to be right next to them. And so when they were slowly given information, it happened right before their child died, at a point where they weren't able to process very much, but also when they wanted to focus on their physical care for their child. And we see Mama Brian's story and many others also show us that navigating the health system caused substantial suffering for families at the point of their child's death and throughout the immediate point after their child died, in the immediate stages of bereavement. Parents in hospital and families back at home were frequently very stressed by the health system and the responsibilities put on them. Families described distress as their child deteriorated, as they looked back on their experience and wondered if their child might have survived had they been referred and diagnosed earlier. And so we found that families wanted information about what caused cancer, how to prevent it, early signs to look for as a parent, the processes of cancer, the mechanisms by which some children do die from cancer. As one father said, that is the worst part of it. As parents, we're left naked, absolutely naked. This had an impact on their relationships with communities, who often would spread rumors or make accusations related to the child's death and to delays in releasing the child from hospital or the mortuary. Or questions around the high hospital bills and the harambes or fundraisers that the family had to hold would cause a lot of tension in their community and family. And so we can see that this inhibits families' ability to make meaning and fulfill some expectations and rituals around mourning their child's death. But we can also see how these structural components throughout a child's illness have an impact on a family's end-of-life experience. And so the end of life is not really an isolated component of care, but everything that happened leading up to the child's death has a significant influence on the family's experience as they're navigating that, as they're making sense of their child approaching the end of life. They're questioning all of the steps along the way that led them to that moment, which is causing significant distress internally for them, leading to many of these crises of faith, asking why it would be God's plan for the health system to have for them to have kind of fallen through some of the cracks of the health system, or why it would be God's plan for it have taken so long for their child to get diagnosed, or that really makes families, and particularly the parent in hospital, struggle substantially in that space right as their child is dying, making it very hard for them to receive comfort themselves and comfort their children. And that also has ripple effects that causes challenges between them and their community, and for their community as a whole, to make sense of how this child died, and how then they can comfort the family and the parent in bereavement. We also saw, though, that Mama Brian's story and our experience conducting this study demonstrated the importance of culturally and contextually relevant care right at the point of the child's physical death and into bereavement. Families are often alone while waiting for their child, particularly in tertiary hospitals, as you know, like Moy, where the family may be very far from home and one parent might be the only one present at the time that the child physically dies. And so families are waiting on the ward for several hours for their extended family to reach them. This has an impact on that parent who is there waiting on the ward, and for the other families around them who have just witnessed another child die and are attempting to be supportive to this one parent who is now grieving, while also continuing to care for their own child. And as we saw, parents are constantly comparing, and so it's very distressing for a parent to watch another child die, and then, as one parent told us, you watch one child die and then you look back at your own and you think, are they next? And the impact of that on parents. And so we found that for families who were the parent who had the child had just died, that they found a lot of support when someone simply sat with them in that period. They found it very meaningful when doctors who had worked with their child closely came and spoke to them, however briefly. And other parents tried to support, but this was often very hard on all of them. There were also many complicated feelings around their child and the body of their child and where the parent wanted to be while waiting for the mortuary. Some parents wanted to remain in the room with their child. Others did not want to be anywhere near the body. And so that required kind of flexibility and listening to families very closely to hear what would be most helpful for them, and not trying to force them to view the body necessarily, or to stay away when they wanted to be close. There are also challenges of the family only seeing the child once the body has already gone to the mortuary, and wanting to see the child after they had died, but it being very distressing in the mortuary environment to be able to observe the child in that way. Many families also described immediate distress about their hospital bill as soon as their child died. And so many families immediately following death were trying to navigate hospital processes. They were in the very immediate and early stages of grief, and were standing in discharge lines with children who were going home, and they were there trying to process their deceased child's bill. We did find that some families described suicidal ideation in this time, thinking that they had no way to pay their child's hospital bill, the pressure of going home, and the sort of shame of their child dying and returning to the community. And so having someone help them navigate those processes was a very simple way to shift some of that experience and to move through that alongside them. Some of those processes are not avoidable, but having someone with them to move through that made a significant difference, not just at the point of illness, or at the point right after the child had died, but many families described as their child was deteriorating, they were already starting to think about the hospital bill. And so they were distracted thinking about what they were possibly going to do, how they would ever pay for this. And so potentially knowing that there would be support for them, that they could kind of set that aside while their child was dying, could be a form of comforting the child and the parent as the child is deteriorating. Allowing the parent to just focus on care for the child as they die. We also found that having people from the hospital who remembered their child coming all the way to their homes and continuing to visit them gave families an opportunity to remember and talk about their children after their deaths. And so we found that our kind of methods of accompaniment, walking alongside families, were a great source of support. Families did find significant meaning in recording and documenting their child's life and death, as I described with Mama Brian, and particularly being in community with other parents who had lost children, particularly those who they had known in hospital and had gone through the physical experience of their children's illness and death, was significantly meaningful to families. But accompaniment doesn't only have to happen after the child dies or in bereavement. I think accompaniment is really about walking with families as they are and making space for families to tell us what is most important to them and to direct their care and their interactions with us as care providers in these very important and complicated and sensitive areas. Such as around how to communicate about their child's end of life, how to navigate some of their existential and spiritual suffering around their child's death, how to move through the experience and think about what they wanted as their child died. So accompaniment can take many forms, and it can be very complex, but it can also be simple. It might look like taking a few extra minutes during ward rounds to ask if families have any questions. It could be being sure to translate and explain what you're noticing about a child's condition, or potentially as someone who's an allied health professional following up after a clinician's visit and processing what they have heard with them. It could be having someone explain and walk through bill processes with families throughout their illness so that they, at the point that their child is dying, they are able to focus right there with some assurance and trust that someone will help them with the next stages. Taking extra time to hear what parents understand of their child's condition when they may be approaching death, and appointing someone as an accompanier with families after their child has died in those immediate hours, as they're thinking through taking their child's body home, or processing the burial, waiting for families, navigating the ward right after their child has died. And then it could extend into bereavement, and it could look like an extensive program like we were able to do. It could also be a WhatsApp message or a call a couple of months after a child's death, just to note that their child is still remembered and you are still with them. And so really in all of these findings, we can see that families during their child's illness and death are expressing wanting people to be alongside them. And we can see that care for families that is culturally relevant and sensitive has to take many forms, as families have many different beliefs and relationships to those beliefs and experience. And so many more than any specific words or action that will be the perfect end of life care. This might be more about a way that we approach our care by making space for families to have complicated and diverse experience and finding ways to support their ability to care for their child to their fullest ability, as that looks for them and in their context and culture. So I think due to time, I'll skip this summary slide, but happy to return to it about some practical, just sort of a summary of some of the practical components that I mentioned around family-led dialogue, facilitating peer connections between families, integrating family-led spiritual care where families have space to navigate their questions rather than being told what to believe, but seeing their kind of wrestling with their faith as an expression and enactment of their faith and spirituality. Practical guidance and clinical presence for families on physical care during active dying, so that families know how to physically care for their child in those stages without necessarily needing to label that as dying or having to articulate explicitly that their child will die, but giving them practical tools to be able to continue caring for their child and relieving some of their child's most distressing symptoms in that time, so that they can continue to have a relationship with their child and enact their parenthood over their child. While in the back of their mind, they may know that's the end of life, you don't necessarily need for it to be announced as now the child is dying to be able to continue caring for them. There are also some very simple things around administrative processes and streamlining those, or appointing an accompanier or a health system navigator to help them walk through the end of life, and thinking about family-led protocols around the body and around all of those steps around care, about where the child goes as they're in active stages of dying or right after they've died, thinking about how we could design those alongside families, or for our protocols to be that we are directed by families themselves. And so ultimately, this is, as I said, about walking with families and opening space for them to lead. And so I would love a discussion now about what this might mean in your context, and how we could think about that a bit more. I will also note that I'll put in a QR code quickly before we move to that discussion, that for those who are clinical and are interested in some of the physiological comfort that you can also provide to families, I'll add a QR code for ICPCN's e-learning hub, where there are end-of-life care modules that are more focused on physiological symptom management, that a clinician can provide. But what we found in these stories is that those physiological symptoms and relief of those are very critical for families. But these stories also note that often what is most comforting to families are these broader holistic forms of support and mechanisms for them to be able to care for their child as they die, whether or not we're openly discussing it as such. So I will add that QR code, but we'll just kind of note that my thanks that these results were presented in honor and gratitude to the families and the children, Brian, Princess, Goatman, Faith, Divine, Kimo, Gideon, Anastasia, and Maundi. I also thank my research team and collaborators in Kenya, some of whom might be with us today. Dr. Zipporah Ali was on my thesis committee, and Dr. Festus Njuguna at Moi Teaching and Referral Hospital, and then particularly my immense thanks and credit to Gladys Chepkorir and Elizabeth Kabuthi, who made the Nafasi Kati team and who made this work possible. So that's all from me, and here is the QR code if you're interested in getting some more training from ICPCN. This is free and available to all.
Thank you. Thank you so much, Callie. And I see the claps and the appreciation coming your way. It has been an insightful session. And even as we continue to learn together, just a few key things that have stood out for me. And I like the name Nafasi Kati, like standing the space. Yeah. Seems families do want information, but there might be do we say a conspiracy maybe that's a question we can answer, and it's also been asked on the chat. Is it written somewhere that parents or caregivers should not be given information? So that has come out in your study. And then the fact that children may know what is going on even when we don't tell them, even when we keep quiet and try to speak about them outside the room, there's a lot going on. Then the issue about peer support being a double-edged sword, it could be having its pros and cons to it. So how to engage meaningfully through peer support, and then seeing how our hospital systems, billing processes could be improved to help these services for children and their families. And then just looking at having navigators, that's one of the things you've mentioned, would probably also help these parents and navigate, or the caregivers navigate that situation. So there is a question that came in earlier, and the question, you could help us practically. So how do we break news to the siblings, friends, and classmates once this child has passed on?
That's a really good question and an important question. I think there's a lot more we can understand about how we might best do that. I think our study touched on that to the extent that families raised it as a concern, but didn't explore it in full depth. And so I think there is still a lot more to understand about how we can best communicate with children who are learning of their child's or their siblings or their friend's death. I do think what we saw in the stories that was really important was that just as we saw that the children who were dying were often aware or highlighting some awareness of their approaching death, many family stories also highlighted that the children in their family were aware of what was happening to their sibling or their friend, even without being told. And sometimes not being told led them to some confusion and distress. One family described that the very young siblings frequently went to the grave and they were asking their parents to bring the body back, that they wanted their sister back, and they didn't understand that their sister had died. The family didn't tell them that the sister had died. They just said that she was resting, and that led them to be very confused and then ask questions about why the sister wasn't coming back and why they wouldn't bring her out of the ground. And other families we saw who didn't think that the siblings were very aware of what was happening, but we found, or friends, but the child's friends would come to the burial and mourned the child very openly, and so had awareness of what was happening and had grief to experience even without being told. One family story that I found particularly insightful about this was her child's friend, her closest friend, came to the burial and mourned the child, but then every Sunday would continue coming back to her home and having tea with her. He was young, he was maybe 7 or 8 years old. And I think she described that as something that was healing for both of them. She thought, even though this was a young child, they didn't ever kind of openly discuss the child's death with her son's death with the boy or with his friend. But they continued to have a relationship with each other, and he continued to come over for tea, and it was kind of a way, I think, for both of them to kind of mourn and continue to remember her son. And she found that very surprising, that this young boy was so aware and paying attention and knew that she needed support, and also knew that her son was gone. And so I think in terms of the specifics about how you communicate with children, there are some materials and guidance that I'd be happy to share from others who have developed that. I think there's still a lot more we can understand from families and from children themselves about what they know and what they want to be told. But these stories certainly raised that just as the children who are dying seem to be aware of what is happening, I think their siblings and friends are also aware, and open communication, and communication that maybe isn't even direct, but makes space for them to memorialize and remember their friend or their sibling, will make a big difference to that child, because they are grieving, and they do understand to some degree, and so they need presence and support as kind of makes sense for them at their age.
All right, thanks for that. There was a question about are health workers trained on grief and bereavement? I would say it's an ongoing conversation. I don't think anyone is perfect there, and it's not easy. It's never been easy. The journey itself, and we will also share the e-learning materials that probably we would empower ourselves as health workers so that we are able to work with the patients. But the palliative care providers near you are also empowered in that way, and they continue growing in information sharing, just knowledge, and let's engage them. If you have a palliative care provider where you're working, do work with them. And I know the Child Life team, MTRH has a team who also do a great job in that sense. So do engage them as a team. So there are comments, many of them saying this is the situation also in my facility, common in low and middle income countries. I don't know, Callie, did you find any reason at all why the child's diagnosis was being withheld from the guardians by the medical personnel?
Yeah, that's a tricky question. I think first I would preface that I did not directly, I worked with families rather than clinical professionals. And so I want to be careful about what I say about why they do things, or making any suggestions about their motivations, because I think a next study for me, and there are others who have studied this, hearing directly from healthcare workers is important, because I think just as the families, there are very complex reasons why they might decide not to communicate something, that might be partly about their personal decision and partly about many complicated structural factors. I think I saw in the chat one person noting that just the volume of patients and how difficult that makes it to provide care at the end of life. And I do honor and note that. I think when we think about this, that clinicians and healthcare workers are working in very difficult circumstances without a lot of support often, and so that might contribute to how they communicate with children. And so I think these stories and what we've seen can help us think about how we might start to change some of those systems. But I don't want it to indicate to us that we blame clinical providers as individuals for how they go about things. But it might indicate that maybe healthcare workers need more support to be able to move through those conversations. I do think, that being said, I do think in this context, or with these family stories, what it seemed to be was that many healthcare workers, I think twofold. I think partly they were nervous to communicate a prognosis to a family without having the capacity to help them move through that, either psychologically, emotionally, and spiritually. They didn't know how to have that conversation in a way that they could kind of support the families processing that information. They also maybe didn't have kind of the mechanisms to provide continued support to the family. And so their perception was that it was better for the family to not know. And then it would come as a surprise, because there wasn't much they could do to help the family anyway. And so it seemed like it was futile, or not beneficial to have the family know what was happening and have nothing to do with that information, or no way to kind of respond to that information. I think there is also a perception that it is too distressing for families to know, and that they would rather be surprised, and that knowing anything about their child is only distressing. And some of that, I think, comes out of a perception that if you don't tell the family, then they won't know anything. And I think one of the main things that we found in this study was that families know a lot about what is happening without ever being told. And so that sense that if I don't tell them their child is dying, they'll be able to live and continue caring for their child as if they know nothing that's going to happen. But families often did know quite a lot about what was going to happen to their child, even without being directly told by a clinician. And so I think sometimes there's a sense that if we don't tell them, then they're able to continue living as if their child will continue living, and that will give them kind of a bit better quality of life before their child dies, because they'll be able to live more fully and won't have to live in that space where they're aware that their child is going to die and not have anything to do. Those are some ideas. I think there's, as I said, many complicated reasons why clinical providers might make that decision that might be different in different contexts. I think I don't know for sure why in Mama Brian's story particularly, why she was never told the diagnosis. I have some ideas, but I think also clinical providers have, there's a lot we can still understand from their perspective about why they might make that decision, or what might encourage them to make other decisions around communication.
All right, thanks for that. I'll give Patricia a chance to speak. Your hand is up, so you can unmute and speak. Patricia, if you can hear us. Okay, maybe not. Patricia, are you able to hear us? Yes, now you're unmuted. You can speak.
Okay. I think I pressed it accidentally. I didn't intend to ask a question or to speak, but otherwise, thank you so much for the great presentation. There've been a lot of insightful things that I've learned from the presentation. Thank you so much. And most of the cases that have been presented, we meet them each and every day. So thank you so much for the great presentation.
All right, thanks Patricia for the feedback. And let me see if we can get another question in. There was a question about okay, a lot of thank yous and well done for the presentation. There's a request for the published research. I don't know if that's available and you're able to share with us.
Yes. So the thesis in full should be available online, open access, in the next 1 month. So I'm happy to share the link where you will be able to find that. I am in the process of publishing sections of the thesis now, and so I'm happy to continue sharing those as they become available. It's not quite yet published, but I'm happy to continue sharing those as they're available.
Okay, thanks. There's a comment or a question. I know of a bereaved mother who couldn't let go of her child's belongings and would often hold and smell the clothes to feel connected. Is this normal? And what is the recommended way for caregivers or professionals to support someone in this situation?
Thank you. Yeah, that's a very difficult question and circumstance. I don't know. I think I saw Joyce Washira was on the call a bit earlier. I'm not sure if she's still here. Joyce Washira is the director of Tears Foundation in Nairobi, and so she has much more expertise on particular forms of grief support for families who have lost children. I do think I would encourage. I think we heard from families frequently that many parents had that experience of having trouble letting go of physical items or continuing to think about their child and not really knowing if that was normal or okay or allowed. And I do think this is where tears work and work like that is so critical, because much of the support that families received from tears in our study was just education about what grief is and what it looks like and what to expect and what is normal. And that made a big difference to families so that they could make sense of why they might still want to have the child's clothes and what it meant for them to smell the child, have the child's scent around them, and to not kind of feel shame necessarily about having that emotion. And it helped their broader family and community be able to support a family or a parent while they were experiencing that, and not necessarily be worried that that was a significant problem. And so I think I would point toward those who are specifically grief counselors to indicate for a particular case. But I would encourage maybe that grief takes a lot of forms, and I might not necessarily, that might be a step of a process that a parent needs to go through, that won't last forever, but might be where they need to be right now.
All right. I'll give E. I don't know who E is. Your hand is up and you're able to unmute. And meanwhile, Joyce, if you're on the call and you have a comment to add, you could speak after E. And E, introduce yourself.
My name is Eunice Terito from
Oh,
Nyeri.
Eunice. Okay.
Yeah, I just wanted to say that was a good presentation. And when it comes to grief counseling, we mostly, when you're doing it, like for a family, you allow them to talk first. When there is somebody in that group who cannot be able to talk, they run from the others. You start like telling them to highlight anything good or they can remember about the baby, so that this is a way of helping them cheer. And those who cannot be able to talk, by the time all the family members are talking, you'll find he or she will start trying to give her comments or her concerns. When we are doing bereavement support, remember that we want to talk less, we want the family to talk more. Remember, most of them have guilty conscience. They are feeling as if there is somewhere they failed. Our work is to make sure that they understand they are not failures, they did their best, and now that is where they had reached. So that was just an addition, because we feel that grief counseling, nobody can say that I'm an expert, but every day we keep on learning. Thank you.
Thank you. Thank you, Eunice.
All right. If you'll allow me not to come on camera, is that okay? My name is Joyce Washira from the Tears
Yes.
Foundation.
Go ahead,
Thank
Joyce.
you so much, Esther. And thank you so much, Dr. Callie. I had the question, and I just want to say that holding on to clothing or any possession that your loved one had, it's normal, very, very normal. As Callie has said, that grief has so many forms. And one of the way of expressing love that you have nowhere to take because your child has gone is holding on to anything that they had, they wore, they played with, even food they loved to eat. You'll start seeing a parent start eating the same kind of food the son or the daughter that was eating. So what are we saying? That grief, yes, takes a lot of forms. And one way of holding that property or possession is just an expression of love and also an expression of grief, that this is what my child had, and now they are not there to have it. So why don't I hold on to it? So yes, it's a connection that is very normal. And with a lot of support and spaces to validate that, they start letting go. But if they are judged, if they are told to take them away, in fact, there's some family members that actually take them away by force. And that is very hurting. It is very wounding. It is disrespectful and dishonoring even to the family. So part of the peer companionship that Dr. Callie talked about, when a peer, because I think, Esther, you mentioned something, and I think I was doing something else. You mentioned something very important, Esther, that when you are companioning, there's a positive and a negative to it. So that's why Callie was talking about maybe a trained peer, because all of us who are bereaved, if we can all be companions of others who are also bereaved, it means that we'll be companioning them from our own beliefs, understanding, culture, and all that. So we may be rubbing what we know from our culture to others, that was helpful. But if they are trained, you have also lost a child, but you have also trained to be a companion, you'll be able to support them from a point of understanding, and we call that grief literacy, so that you are not rubbing what you know from your culture into someone else. So I hope I've said something useful, and thank you so much for this webinar. It was so impactful, very impactful. I'm so honored that I came. Thank you.
Thank you, Joyce. And you've even given us more ideas, because from the questions, you see, there are many things coming up in terms of how do I navigate this? How do I deal with this? So we'll probably engage further later so that we have those conversations running through these webinars.
Thank you very much, Esther.
You're welcome. There was a question about CPD points that is being addressed progressively for the nurses and the clinical officers. So be patient, but you'll be receiving your certificates of attendance if you met the threshold of time. And I think just looking through the questions, Callie, I don't know if there's anything else you've picked you'd like to respond directly to. We have five more minutes to go. You could just pick and respond to that. Meanwhile, the link has been shared on the platform, so you could look at it later in due time. Callie?
Yeah, thank you. I think I've seen a couple of comments about like what advice would you give to a clinician who breaks down in a family conference, or wondering if there are debriefing sessions, or if there may be a lack of support toward clinicians might hinder the ability to care for families fully. And I just want to note that I think those questions are very important, and I think that is critical. I think I am very glad that I worked on the ward for many reasons, but I think it also helped me a lot in having understanding and a perspective of what some degree of what it's like to be a healthcare worker in that context, and particularly for nurses and doctors and clinical officers who are responsible for the treatment and decisions about a child's care, the weight of that, and the weight of the volume of children, and the number of children that you're seeing, the number of children who unfortunately die. And I think there's so much we can do to support clinicians better, and to that your care and well-being is also critical in this, that you are also watching children die, and that is extremely challenging, and you are exposed to this level of suffering all of the time, and so I think just wanted to note and thank those who asked those questions and raised those points, because I do think that is a critical component of all of this, that those who are providing the care are also cared for.
Yeah, and also it shows us the opportunity there, the need for debriefing amongst clinicians. I don't know how well it's done. From the interactions I've had with clinicians, I know some do support each other, and I know Eunice and your team in Nyeri, you do, but then it needs to be everywhere. Someone asked if this applies to children who have an uncancer diagnosis, and the answer is yes, because it's end of life for any condition. So even as we navigate that, if there are opportunities that come up to support clinicians in this sensitive fields, I know pediatric palliative care, and especially end of life, is not an easy one. But we can make it easier if we support each other and we keep learning. I'll give Jen an opportunity to speak since her hand is up, and then we'll wind up today's session. Jen, go ahead. Jen, you can unmute. Jen Olago.
Okay, I hope you can hear me now.
Yes, we can.
Yeah, good evening, everyone. Okay, as a counselor, I had experienced once a mother holding on to 1-month-old baby, and who had died, who had passed at the hospital, and she refused to let go. So I was called to go and talk to her to give the body, because they wanted to take to the morgue, and she refused. So I let her. I told the doctor and the nurses to just let her cry, because she was crying and talking to the baby. And she held on to the baby for 3 hours. It was quite distressing. But by the time now they came to take the baby, I could see that she had accepted for the baby to be taken, for the body to be taken. Yeah, so that was quite distressing, even for me as a counselor. But I was just there for her. I didn't say anything, just rubbing her back. And she was talking to the baby and talking back to me. I didn't answer anything. I was just nodding and letting her go on. Yeah, so sometimes even us as counselors, we go through a lot. Yeah, thank you. Yeah, thanks for the, yeah, thank you, Dr. Callie. I like the presentation. Thank you.
Thank you, Jane. Oh, sorry. Yeah, I think you've raised a really important point about accompaniment, that you've connected well to some of those points around accompaniment, that sometimes it just looks like presence, and being there, and not necessarily, sometimes we don't have words, and that's okay. Sometimes it's just physically being with someone, and that can make a big difference throughout the end of life and into bereavement. So thank you for your comment, Jane.
All right. I think this comment will actually wrap up our discussion today. Michael says that it's normal during the grieving period that the parents hold on to the child, and at MTRH, the child life specialists help parents create keepsakes for their child's memories. And then Liz, who's a child life specialist, who's part of this project, says, thanks for the great, rich, and enlightening webinar. Always a joy listening to you speak about Nafasi Kati. Great moderation. And Joyce, thanks for your input. 1.5 hours is not enough. So this is to Kehpca. We'll need more sessions. I'm sure they've had and they'll work on that. So being mindful is really important, even as we navigate this space. I'll give you an opportunity to share a parting shot, Callie, and then I'll do the final remarks. And thank you so much for your time and for the insights that you shared with us. We look forward to continued collaboration and engaging with you. So your parting shot.
Okay, thank you, Dr. Esther, and thank you all for being here and for engaging so closely. We've told Mama Brian that we were sharing Brian's story, and so So thank you for listening and hearing Brian's story and carrying it with you. And I think it's really inspiring and wonderful to see your passion and dedication to this space and to the families you work with, knowing that it is often very challenging work, and requires a particular person to be able to do it. And so mostly my parting shot is thank you so much for your care, and if there are ways that my study or these family stories can continue, if we can continue to think about how you could learn from them and implement them, I'd be very happy to continue the conversation. I can put my email in the chat, and if there's ways that ICPCN can also support you in that, we would be very glad to, because we're inspired and greatly impressed by your dedication to Kenya's children and to children everywhere. Thank you.
Thank you. Thank you so much, Callie. And Tim, thank you so much for joining today's session. We wind up 2025 webinar series on palliative care, and we hope to continue in 2026. The other thing is we have the Palliative Care Conference coming up in February next year. So look out for that. Come, let's share and learn together and also network. We also have the Inter-County Palliative Care WhatsApp Forum, which you could plug into and have conversations on palliative care or challenges that you're going through, or share strategies that are working where you are. For the question on the recording, the webinars are all uploaded on the Kehpca YouTube channel. So if you go to that channel, probably in a few days, this one will also be uploaded, but then you can also listen to the past webinars. Dr. Zippy also passes her regards. She was not able to join today, but she knew this session was going on. How to join the Inter-County Discussion Forum. I don't know if the link could be shared on the chat. If Josephine, you're on the call, or reach out to any of us. If you know anyone from Kehpca, just reach out to them and they'll be able to share the link with you. YouTube, write Kehpca, or someone can share the YouTube link, the Kehpca link, but just look up Kehpca and you'll be able to see the conversations. Callie's email address is on the chat. All right, you can copy it and use it. There's a comment from Kehpca. Please text to the number on the chat, 0722 507 219, and you'll be added to the WhatsApp group if you're not yet there. Thank you so much on behalf of the organizing team, on behalf of Kenya Hospices and Palliative Care and the Palliative Care Network in Kenya and beyond. We are really delighted to be having you join our webinar sessions each and every month. Asanteni sana. We will stop the conversation here, but we'll continue wherever we are. Thank you. Thank you, Callie. Thank you, team, for joining. Have a nice evening or a good day wherever you are. Bye.
Thank you.